All right. So my name is Mike Wagner, and I'm going to be talking to you about point-of-care ultrasound for the next 2 hours or so, which is kind of a daunting time slot, but it's also a little bit daunting in the sense that I have to condense all of sort of point-of-care ultrasound into 2 hours. There's a lot to potentially discuss, and I want to kind of paint a very sort of broad brush for those of you who haven't had any or much exposure to point-of-care ultrasound. This is my contact information, and I'll start off with just a little bit of background. First of all, I don't have any disclosures, financial conflicts of interest, anything like that. I'm not on any payroll of any ultrasound company. I don't have a pending ultrasound invention or anything like that. My interest in ultrasound started in residency. I did, well, I'll take a step back. It did start in my OBGYN rotation when I was a third-year medical student, when I was actually relatively useful because I was one of the few people in the triage area that actually used the ultrasound to determine, baby head up or head down. And that actually made me relatively useful as a third-year medical student. Then I went on to the internal medicine residency and I thought about doing a cardiology fellowship, and I had a mentor who was trying to convince me to become a cardiologist, and I learned echocardiography during one of my rotations, and he had me scanning with sonographers and things like that. Immediately went on to do an ICU rotation, a very busy ICU, and found that, wow, the ability to do point-of-care echo was very useful in the ICU setting, and it was there I had my first exposure to a pocket ultrasound device, and I've been sort of hooked ever since. I spent a bunch of time in the Navy, about 7 years in the Navy, doing aerospace medicine and internal medicine, and then I left to do a primary care or general medicine ultrasound fellowship to get as very proficient with ultrasound in as short a period of time as I could. And there I've stayed on to kind of be the director of ultrasound education. So that's my background. Just by show of hands, let me understand who I'm speaking with. So how many of you all are generalists, meaning family medicine, primary care, internal medicine, that sort of thing? Okay. And then how many of you all are OBGYNs? So about split, about half and half. Okay. So my objectives for this talk is to sort of define bedside or point-of-care ultrasound for those of you who aren't familiar with it, and then really to help you distinguish it from consultative ultrasound or specialty ultrasound, or how ultrasound is used in a more traditional sense, particularly in the United States. I'm going to describe some applications of point-of-care ultrasound that I think are most useful to the generalist, but we'll talk about some ways that you can use ultrasound as an OBGYN and just sort of go beyond OBGYN ultrasound with the same probe and using just slightly different techniques. And then we'll identify, a lot of barriers to using point-of-care ultrasound, and then maybe some strategies and brainstorm on how to kind of overcome some of those barriers. And so I always like to start things off with cases, and this talk is very case heavy, just to keep things sort of interesting. So taking care of, say, a COPD patient in the emergency room, and this is her zillionth hospitalization for COPD, feels like a COPD exacerbation, coming in, short of breath, hypoxic. She gets attached to a non-invasive mechanical ventilator, feels like things are initially improved, and then over time in her ER course she starts to do worse, becomes increasingly tachypnic, increasingly hypoxic, more distressed. You look at her chest x-ray when she was first admitted to the ED was normal, and you don't notice anything on physical exam that's particularly telling, and so you call respiratory therapy. The settings, seem like they're going up on the BiPAP, and then very quickly she starts to very quickly sort of decompensate. Heart rate's going up, blood pressure's going down. She's looking like she's going to crash. And you call for help, and the emergency room physician comes in and grabs an ultrasound probe as they're coming in, and they apply the ultrasound probe to her chest. And so they just pop the ultrasound probe on the chest here, and on the right-hand side they see, they see an image that looks like, hold on, I did that wrong. they see an image that looks like this, okay? And they're like, very concerning. Then they go over here to the left, and they get an image that looks like this. And they're like, okay. They come back over here to the right, and then they slide laterally. They get an image that looks like this, slightly different than this, sort of halfway between this. And they see just this unusual artifact pattern, and they're like, get me a chest tube. They call for a chest tube kit. They put in a chest tube on that right-hand side. Big rush of air comes out. The patient sort of rapidly, the tachycardia goes away, the blood pressure comes up. You know, they had a tension pneumothorax, and they kind of rapidly save that person's life. Meanwhile, about 20 minutes later, the x-ray tech is coming in with the portable x-ray machine, kind of, hey, do you still need this? No, we don't need it. So what is this? The first time you kind of look at this is lung ultrasound, and it's, it doesn't look like anything that you've used to looking at. And if you're like me, the first time you kind of get exposed to something like this, it's like, well, this is witchcraft, this is voodoo, like what's going on here? And so what this is lung ultrasound. It's all about artifact interpretation. So air in the chest doesn't allow ultrasound beams to penetrate and show you the tissues as it normally does, say in like looking at a baby or looking at the uterus or something of that nature. And so you can only see the surface of the lung. And so what we're looking at here is we see rib here. You see the chest wall anterior, close to the probe. And then deep to those ribs is where the surface of the lung is. And then all of this stuff here is artifact. And what you're seeing is intermittent sort of movement along the surface of the chest wall. And this is where, under normal circumstances, the lung would touch up against the chest wall. And you would see it sort of move and what we call slide back and forth with normal respirations. But in this setting here, you're seeing sliding and movement, and then no lung sliding. And sliding, no sliding. Sliding, no sliding. And what that is that the spot where the partially collapsed lung is actually, with inhalation, is coming up and touching the surface of the chest wall and getting that little bit of sliding. And then with exhalation, that part of the lung is now pulling away from the chest wall, and you can't see that lung sliding anymore because the air in the chest is blocking everything. And so we call this a lung point, and it's 100% specific for pneumothorax, according to kind of the literature around it. And so this is very specific for pneumothorax, and you can treat these patients urgently, especially if they're decompensating in front of you, right with just this information. And so lung ultrasound is kind of like this, right? This does not look like the heart. But does anybody look at this EKG and recognize this person has a heart problem, right? So you might look over here to see the ST elevations here and the anterior leads. This person, we are not the droids this person is looking for, right? They need another doctor. So it's just like that. The EKG doesn't look like the heart. EEGs don't look like the brain, but the artifacts they create or use give us lots of useful information. Lung ultrasound is just like that. And lung ultrasound, I think, is a great example of what we call point-of-care ultrasound. Point-of-care ultrasound is kind of pushing a lot of the frontier about what we traditionally use ultrasound for and really expand it. We're getting more and more people exposed to smaller, more portable devices, and then the applications are really kind of expanding beyond what we would normally consider standard ultrasound. But one key difference is we're not trying, and in terms of the ultrasound, it's always going to be performed rapidly. So a point-of-care ultrasound exam is not like a 30-minute test. It's 5 minutes, less than 10 minutes is typically the benchmark that we use. It's got to be integrated as part of your bedside evaluation. So instead of trying to condense a full ultrasound exam to just be really, really fast and talk like kind of the Micro Machine Man or like one of those drug rep advertisements talking about their disclosures, no, we're not doing that. We're just trying to limit the scope of the exam so that we're only asking goal-specific questions. You know, does this patient have a pericardial effusion? Does this patient have normal left ventricular function? Does this patient have a pneumothorax? Those very specific questions, and then we use ultrasound quickly to answer those specific questions. A lot of times people refer to it as kind of augmenting their physical exam beyond what they can do with their hands or their stethoscope and things like that. It's not to replace sort of a formal study. So if your clinical question in your mind is something like, you know, not like, does this person have, you know, gallstones, but it's more like, is this aortic stenosis severe enough to warrant a valve replacement? You know, you should be using sort of your standard formal consultative studies. And so, you know, when we talk about point-of-care ultrasound, this has come hand in hand with the development of ultrasound machines. And so, for those of you with no ultrasound experience, if this is like your mental construct of an ultrasound machine, you know, this kind of Soviet-era ultrasound machine takes up half of a room, takes two people to kind of wheel around and move, you know, we have to kind of bring you up to speed. The ultrasound machines are becoming, you know, much more slimmer, more user-friendly. Touch screens are big now, and then even laptop-sized devices as of the early 2000s. And now, you know, pocket-sized devices are on the market, and even devices that will plug directly into your smartphone and run on an app. So there is an app for ultrasound now. And that you don't even need a cord anymore. Some of these devices are actually using Wi-Fi networks and local Bluetooth networks and transmitting directly to a tablet or phone. So the technology is really moving forward quickly. So another key distinction with point-of-care ultrasound is unlike refer ultrasound, where the person who's asking the clinical question and then deciding on the, you know, test to do in terms of, you know, the imaging modality or what have you, is different than the person who actually acquires those, let's say, images, and then might also be different than the person who then interprets those images, which then goes back to a different person, you know, the original person having to act on those images. It's kind of this scattered workflow. It's much more similar to your your physical exam, where you're asking the clinical question right there at the bedside, and then you're performing the image. You're acquiring the image yourself, interpreting it yourself, and then acting on that image. So the workflow is very streamlined with point-of-care ultrasound. Also, we use it not only to diagnose people with conditions, but we'll also use it as part of our treatment. And the most common example of this is using it to guide interventional procedures. So, you know, people have been doing ultrasound-guided OBGYN procedures for a long period of time. We now do this with thoracentesis, paracentesis, central lines, arthrocentesis, carpal tunnel injections, all sorts of different things. We then can use ultrasound to monitor patients for improvement or no improvement or decompensation. So this is another key difference with point-of-care ultrasound, where instead of just doing a one-time snapshot, we're doing the same sort of exam over and over and over again because it's conducive to that. And then we can also incorporate it into screening, and this is more like in the primary care world, screening for AAA and things like that, people who are underserved. So this is my obligatory aerospace medicine slide. It's interesting to note that a lot of the developments that came out of the point-of-care ultrasound movement were driven by developments at NASA, because there is no X-ray machine on the International Space Station. There's no CT scan. And so there is an ultrasound machine. And so you can kind of imagine from Apollo 13, you know, the Ed Harrison's character who, you know, is surrounded by a bunch of really smart guys who are all chain smoking and drinking a bunch of coffee, and they're like super brilliant, and they're like, oh, what can we get out of this ultrasound machine? But we got to run it on the watts of a vacuum cleaner, right? And so they're doing ocular ultrasound, they're looking at intravertebral disc height, they're looking for kidney stones, all sorts of complications that occur that are unique in space. So this is really exciting, and it's led to just a ton of applications of point-of-care ultrasound. This slide is designed to be a little bit busy because point-of-care ultrasound, there's a lot of stuff happening, and we now tell you know, medical students and things like that, you can ultrasound pretty much from head to toe. and find useful clinical applications, whether or not you're a specialist or whether or not you're a generalist. And I think this comes at a critical time for us because there's, I think, an increasing sense with people's lamentation with the sort of death of the traditional physical exam or the demise of the physical exam. There's been multiple editorials, articles written about this, how our traditional exam skills are deteriorating. And I think part of that is people get this sense that there's a giant gap that's emerging between what we can accomplish using advanced imaging and then what we can accomplish using our hands, using our stethoscopes. Which, to be fair, the stethoscope is celebrating its 200th birthday, so it's a little bit of some old tech. So no question there's a big diagnostic gap. Ultrasound can then help sort of bridge this gap and sort of bring the emphasis back to what can we do at the bedside with our physical exam, and then feel confident about that. In terms of ultrasound, it's the same technology we use to look at babies, right? And we've been trusting ultrasound to do this for many decades. And so because it is safe, it's also repeatable. And we feel pretty guilt-free about repeating ultrasound exams throughout somebody's hospital stay several different times. What I really like as somebody who teaches physical exam is unlike looking in sort of the back of the eye or unlike having somebody else feel for say the splenic tip or the liver edge or something like that, which is highly subjective and I can't share in that experience with the learner. Ultrasound is very shareable. And so, very often some of my med students will be like looking in the back of the eye and I'll be like, oh yeah, I see the disc, I see the disc. But with ultrasound, when we're ultrasounding the back of the eye, they can't fake that they see the back of the eye. I can see what they see, right? And so, yeah, I see the back of the eye. No, you don't, right? And so, it's just really helpful from a teacher-learner relationship because we can all sort of share the same experience. And that's useful from a teacher-learner standpoint, but also from a consultative standpoint. It's a lot of times very nice for me to kind of just go to a consultant, kind of say, hey, here's what I see. This is why I'm consulting you for this particular concern, and they can see what I can see. And most of the time they're like, yeah, I agree, but sometimes, they might be like, well, your plane of cut here might not be exactly on, let's do like a formal study or let's think about other things. Another thing about ultrasound is real time, right? And so unlike an MRI, this is an example of a shoulder, and this is the supraspinatus as it kind of goes up underneath the acromion. And unlike an MRI, which is a static image of a muscle, the ultrasound allows you to assess not only structure but also function. And you can view things in real time. You can see things dynamically. And that's useful especially when you're doing guided procedures. So if you're putting in a line or an IV or something like that, you can actually see where the objects are. You can actually see where the needle goes. And then, of course, it's becoming increasingly cost effective as the cost of the machines are going down. So I would like to talk to you mainly for the most of the time today about a lot of the different clinical applications and using cases to highlight that. But before that, how many of you guys have a absolutely, really bare minimum ultrasound exposure? A fair amount, okay. And so I think it's important that we just touch on, and rather than give you a whole big lecture on physics and things like that, which would just be painful and awful on everybody's account. We're just going to simplify just a couple of basic principles for ultrasound so you can understand a little bit of this talk. And again, my goal is not to teach you point-of-care ultrasound in just this talk. It's just to sort of expose you to some concepts of point-of-care ultrasound. And so number one, I like to say, think of the ultrasound probe as kind of like a flashlight shining into the body. All right? And so if you want to see an organ in the body, your beam, sort of, if you will, has to be pointing towards that organ. So if the kidney is a retroperitoneal structure here, my probe has to be pointing retroperitoneally. If my probe is like this, as I am sliding along the body, and it's angled anteriorly, I'm never going to see the kidney. I might see the gallbladder, but I'm not going to see the kidney. The beam has to be kind of pointing to where the object you're looking at. And then that's very critical as far as surface anatomy is concerned, because the probe has a tendency to sort of slide all over the body when you're first kind of learning how to use it. And so if your probe kind of, as you're moving, is sort of slowly sliding more and more this way, and you're trying to see something back here, you can't really see it. Another key thing is that this ultrasound beam, as it comes out of this flashlight that's shining into the body, this ultrasound beam is a two-dimensional beam. And so the image on the screen is a two-dimensional image. But you're scanning objects that are three-dimensional, and that translocation can be confusing. So it depends entirely on the plane of cut. So the probe is oriented with the beam is perpendicular to the, or not perpendicular, parallel to the probe marker. And so as you rotate the probe, that will change the image. So you're taking a 3D image and making it 2D. And a good example of that is here. So if you're looking at a tube and the beam is in cross-section in relationship to that tube, the image on the screen you're going to see is a circle. Whereas if you rotate the probe 90 degrees and now you're looking at the tube sort of in crosswise, instead of looking like a circle, that tube will now look like sort of a rectangle. And so you have to constantly be thinking, even though the objects the screen is what you're seeing in 2D, the objects you're scanning in 3D, and it's entirely dependent on the probe. Another thing is talking about sort of shades of gray. Ultrasound is just, for a lot of people, a lot of black and white fuzzy images don't really make a lot of sense. A couple of key things to keep in mind when you're interpreting shades of gray, and that is fluid, and probably the most important thing, fluid will show up black on ultrasound. So blood is black, ascites is black, pleural effusion is black, pericardial effusion is black, fluid in the bladder will be black. And whereas all the tissues will be, varying different shades of gray. And so the more dense the tissue, the brighter the image will be, and the less dense the tissue, the darker the shade of gray. And then things that are highly reflective of ultrasound surfaces, so things like air, bones, gallstones, they'll have kind of a very bright white appearance. Okay? So we'll start off with procedural guidance. You have a guy comes into the emergency department, and he has end-stage renal disease and liver disease. And he has known history of ascites, and he's coming into the emergency department because of increased abdominal distension, swelling, pain. You look back and he's had several different ER visits and sometimes hospitalizations for exactly the same kind of complaint. And you look at this guy and you say, he's got ascites. I don't need an ultrasound machine to see that this guy has ascites. And so you say, well, do I need an ultrasound machine to do a tap? And you try to think, well, I'm just going to go kind of down around in here, down around in here. You see that somebody else's before you has kind of gone up in here. Maybe you go to the same place where somebody else has gone and had success. The same spot over and over again seems to be working. And most of the time, that's fine because the incidence of paracentesis complications are relatively low. And with an abdomen that looks like this, probably not going to run into too much trouble. But the problem with repeated taps is that over time you develop these adhesions to the abdominal wall, and sometimes the bowel will loop up against the abdominal wall. And so in this particular patient, they had went to the ER, they had gotten a tap. We can't tell in hindsight whether or not they used ultrasound or not, but it doesn't seem so based on the procedure note. And then he represented later, 24 hours later, septic, hypotensive, very, very sick, and he had a bowel perforation as a result of, presumably a complication from his paracentesis. And so this is an ultrasound image from one of my residents who was, preparing to do a paracentesis, and they were going to put in the needle right at this particular spot. Now, the top of the screen on the ultrasound is always going to correspond with what's close to the probe, right? And so this is right where the path of the needle would go, and you can see that right in front of that needle path here, this is a loop of bowel, and you can see the little villi in here. You can see the loop of bowel just tacked up against the abdominal wall. And so this is an example of a clear-cut sort of save. This is another image. Oh, well, let's stick the needle here. We like to play a game in my residency where I kind of tell them, okay, where do you guys go? If you didn't have ultrasound, where would you put the needle? And then we take a look, and then we, a lot of times I go, whew, I'm glad we didn't do that. All right. Another time is you can use Doppler to avoid the blood vessels, and that applies for the paracentesis as well as for the thoracentesis. And then in the para, the key thing you want to avoid is the artery that goes along with the rectus muscle, but sometimes that stretches out and lateral, so you can't just rely on landmarks. So this is a nice example. In this nice study here, they showed that ultrasound assisting the paracentesis versus using a traditional technique, they found that they had a 95% success rate as far as the TAP versus a 61% success rate using just traditional techniques. So it actually does make you faster in sort of the long run in terms of things. And so here's an example of a very nice successful TAP, the needle coming through the abdominal wall, missing the liver, missing the bowel, hitting this nice pocket of fluid here. Whereas this person here, this is a great example of when to avoid doing a paracentesis, right? And this is a patient who she had metastatic cancer, had repeated malignant ascites, TAPs, and things like that. And this has now all become very densely loculated. Intermixed in all these loculations are loops of bowel with gas and kind of swirling around. And this is not a belly you want to go and tap. The same sort of thing applies with chest x-ray. This is a view with somebody holding the probe across the body, up around here, using the liver and the diaphragm kind of as our window, and sort of moving the probe around. You can see this is all chest on this half of the screen here, and this is abdomen, and this right here is diaphragm, and you can see a little bit of lung wiggling around in the fluid. And you can see this large pocket of fluid in the chest is a great place to do a thoracentesis, and usually that's how it goes. But every once in a while, probably 2 or 3 times a year, we come across a thoracentesis where we go in and, or not a thoracentesis, but prepping for a thoracentesis, and we see something that looks kind of like, there's a Lord of the Rings spider in there that laid a giant web and is filled with loculations and fibrinous strands. And this is not a TAP that's going to go well. This person really needs like a chest tube with lytic therapy or a surgery with decortication, things like that. So it's helpful, in terms of when to do a procedure. Now this story here was a guy who came into the emergency department, and he had a history of cirrhosis, ascites, and he had multiple hepatic hydrothoraces on his right-hand side. So he had multiple thoracentesis on the right. He had just been in the hospital to drain fluid from the right-hand side, and he represented to the ER feeling with his abdomen more distended and things like that. The ER got this chest x-ray, and then they said, whoa, wait a minute. We were consulted because how many of you guys think that this guy has a big right-sided effusion? How many of you guys think he has a big left-sided effusion? How many of you guys aren't sure based on this chest x-ray? Right, and so looking at this, one might think like, this seems like he might have now developed a left-sided pleural effusion. We were actually consulted to admit him and work him up for this effusion because now he's developing bilateral effusions or switching sides and things of that nature. But when we actually looked and set things up, this is kind of us using an ultrasound probe here, focusing on the patient's left-hand side. And what we see here, this is his spleen, and this is his diaphragm. And when he takes a deep breath in, we see this kind of artifact coming down here as he comes down. And what we don't see is a bunch of black. We see kind of this artifact pattern here. And this spine here is eliminated as he breathes in. So this artifact pattern here lets me know with 100% certainty he actually does not have a left-sided pleural effusion. And when we zoom in with a high-frequency probe, we can see the junction between his spleen right here and his lung right there. And that junction there, there's no black fluid in between. So this gentleman does not have a thoracentesis. So we actually spared him. If you go and do a thoracentesis in a person like this based on a chest x-ray, you can cause a pneumothorax, you cause complications, or you might enter into his spleen and do a little splenic biopsy. So this also applies for guidance of central lines. And so in this patient, she was very sick and had lost a bunch of IV access, and we weren't really sure why she was losing all her IV access. And she was now starting to get kind of soft blood pressures, and we really needed access to give her medications. And her blood pressure, while it typically had been running high for most of the hospital stay, it was now kind of borderline, like 100 over 60, 95 over 50, kind of trending in the wrong direction. And my resident went to put in a central line. This is the internal jugular vein in cross-section. This is the carotid artery in cross-section. And what she's doing is she's just pressing with the probe gently over top of the vein just to kind of get her landmarks. And I don't know if you can see this all in the back, but you notice that this vein doesn't completely collapse and that there seems to be sort of something inside the vein. And so she actually had a IJ thrombosis. And you say, oh, wow, this is not a good place to be putting in a central line. Let's come down here to the femoral vein here, see if we can put in a femoral line. Lo and behold, she has the same process going on here. And so when we looked, she was essentially developing pretty much thromboses throughout her whole body. And then we thought, oh my gosh, what's happening here? And we early recognized somebody with severe sepsis. And she actually had DIC, and we got all the panels and things like that and recognized her with DIC, appropriately triaged her to the right level of care, and then we found an open vessel to actually cannulate and get her access. So not only does it help you guide the procedure, but if you integrate it into your clinical thinking as part of what's going on in this patient in the big picture, it can really help you out. We have a case of, this is where a lot of excitement and enthusiasm in managing heart failure. Readmission rates for heart failure are a big source of interest now. And we see that this patient, coming in, has a history of decompensated heart failure, comes in, they're now net negative 2.5 liters or so. They're now off of oxygen. You don't hear any crackles on examination. Their edema seems subjectively better. They're saying, hey, can I go home now? Well, if you put the ultrasound on their chest on both sides and look at their lungs on both sides instead of just listening, you get this type of laser beam type artifact on both sides. And you look through their liver at their inferior vena cava, which feeds back into the right atrium of the heart. And you can think of that as kind of like looking at neck veins. And you see this large inferior vena cava, 2.8 centimeters. And you can recognize that this person is not ready for discharge. So what are we looking at here? With the lungs, we're looking at what we call B lines in the lung. This is a new type of artifact. And you might have heard this term being thrown around. You can think of it conceptually as similar to curly B lines on a chest x-ray, and it's the ultrasound equivalent of artifacts that are created by interstitial thickening, and the most common cause of that is interstitial edema. And so you can think of this as kind of like the ultrasound visual equivalent to hearing crackles, and it's this vertical artifact pattern where it starts at the surface of the lung and streams all the way down in kind of this laser light or searchlight kind of artifact pattern. And this is very helpful for determining people with residual pulmonary congestion. And as you might expect, people with lots of pulmonary congestion, if you discharge them, they're not going to do well in the outpatient setting, and they're going to frequently be sort of readmitted, versus people who don't have pulmonary congestion are going to do better than the ones that do. And so this is being used as a tool to help predict readmission rates, and there's a ton of interest in this on the research side, but it's been surprisingly slow to be uptaken by the cardiology folks. And you say, well, I'm just going to listen for crackles. And crackles has been good enough for me, and I'm going to continue to use crackles. This is a nice little study that showed even if you looked at you compared physical exam directly to ultrasound and looked at the prognostic value for that data, they found that the ultrasound was much more predictive of distinguishing who was going to have an event versus who was not going to have an event. And so looking at that inferior vena cava, this is the liver, and then this is, remember we talked about looking at a tube in longitudinal fashion, so the ultrasound probe is here, slicing the inferior vena cava long ways. And this is right as it sort of dumps right into the heart, which is up in here. If you see the tube here, it's normal in size, and when the person takes a little sniff, it has some nice respiratory variation. Here, this IVC looks like, a giant whale's mouth. It's going to swallow somebody up, and it doesn't move. It's like a lead pipe. It doesn't collapse at all with respiratory variation. And so, as you might expect, just like people with distended neck veins, people with big dilated IVCs have worse prognosis in terms of their outcomes as you follow them over time compared to people who have smaller IVCs. And there's a lot of interest in using the IVC size as a target for treating heart failure. And then, kind of even in a longitudinal study over 36 months, they found that there was a big difference in people with big IVCs compared to small IVCs. And so this is one of my patients who came in from the clinic into the emergency department, not from the clinic, but from home. She had a fall in her shower and was feeling bad, feeling poorly, sort of leading up to this, had a fall, and then was down for a little while and was brought into the ER, found to be an AFib and RVR. And she had a lot of x-rays, and they found that she did not have any fractures or anything like that as a result of her fall, but she did have AFib with RVR. Her heart was tacking away, 140s, 150s, and so they consulted her cardiology group, and they came and saw her, prescribed some diltiazem, trying to get her heart rate down. In the meantime, her blood pressure starts drifting down, and she's in the ER sort of overnight, and then continues to kind of have worsening blood pressure. The heart rate's down, but still a little bit, soft. And eventually, they're getting real concerned about her, and she spikes a fever later on during the ER stay, probably about 6 hours into her ER stay. And then they get labs and x-rays and things like that, and all that stuff starts to come in, and they recognize, maybe she has sepsis, and we got to start treating for sepsis. But if somebody had incorporated lung ultrasound as part of their physical exam and their evaluation as part of the initial assessment, they would have seen something that looks like this. This is holding the ultrasound probe on her right-hand side along the anterior chest and sort of sliding from superior down to inferior, and you see this little chunk that's taken out right in here. That little chunk is normally not there. Usually it's all artifact. You can't see tissue. Well, this looks like tissue, and normally you don't see tissue appearance in the lung. It usually looks like air artifact. This is a different look. It has tissue-looking stuff here, and then all these B lines coming off of it. And this is what pneumonia looks like with ultrasound. And so this could have been easily recognized as the cause for her feeling poorly, dizzy, feeling sick, and then having the fall, and then having resistant AFib with RVR that wasn't responding to your traditional therapies. Now, this was readily recognized on a chest x-ray, but as part of the workflow for this, this all happened late in the game, and her care was delayed. And we know that, time is of the essence in people who have sepsis, and identifying that sepsis early and that infection early has definitely prognostic importance. And so here's a nice little study that showed that identifying the source of the infection in septic patients using a POCUS strategy compared to a traditional clinical assessment. Now, these sensitivities are not great in terms of identifying the source of infection, and that can be challenging. But my point is that your specificity increases to almost 100%. So you got 95% specificity, better than 86%. But 48, less than 50% sensitivity in determining the source of the infection versus 73% sensitivity. And a lot of that was driven actually by the detection of pneumonia with lung ultrasound. Okay, and so you say, well, is lung ultrasound really that good? Multiple studies have shown this now, where they did a pooled meta-analysis and they found that the likelihood ratio of a positive lung ultrasound finding increases the probability of pneumonia by 15, and the negative likelihood ratio 0.03. So that strongly rules it out if it's not present, and then strongly rules it in if it is present. And this is you say, well, I have ready access to an X-ray machine. This is a study that was done in Italy, where they directly compared patients who had CTs and looked at the performance of lung ultrasound and chest X-ray, comparing them directly, sort of head to head, and found that lung ultrasound 81% sensitive, chest X-ray an abysmal 64% sensitive in determining pneumonia, versus relatively equal specificities, but still more specific for lung ultrasound. And so I think, honestly, the days of doing chest X-ray for pneumonia and just looking for pneumonia are probably numbered. We'll probably see that phase out in the next decade or two. Now, in this patient, she also had a history of heart failure with preserved ejection fraction, and in response to all these lowering blood pressures, she kept getting lots of fluid. And so this is another example of her inferior vena cava, which you can tell is big, full, and not collapsing. And you can see that she hasn't, dropped her. This is a heart in cross section. This is her left ventricle, and what you're looking at is this sort of concentric squeeze of the heart. And her squeeze is relatively preserved there when I took a look at it. And recognizing that this big IVC is from her diastolic dysfunction, and also because of all the fluids that she got. So now if she's hypotensive, the answer is not more fluids, right? And so if you look at studies where they used limited echocardiography and IVC management in patients who were presenting with shock, and they used their findings on what to do with fluids and pressors and things like that, they used the ultrasound strategy. They actually had a better 28-day survival. So some significantly improved outcomes using ultrasound as part of their diagnostic acumen in these patients. This is an unfortunate case of a pregnant woman who came in with fever, cough, and productive sputum, shortness of breath. And the diagnosis the suspicion for pneumonia was pretty high, but she had a negative chest X-ray. And then she was very hypoxic. And because of this, she went on to have a CTA, because they were concerned that she had pulmonary embolism, and the X-ray didn't show a pneumonia. And so this poor young woman, she was like 22 or something like that, had a full-on CT scan while pregnant to look for something that, when you looked with the ultrasound, this again is the diaphragm here. This is up in the chest. This is below the diaphragm here. This is the abdomen. So we're kind of coming across the body like this, or in this case, like this. And using the ultrasound beam to view into the chest, you can see she's got a little bit of black around her lung here. So she's got a small little pleural effusion, but she's got a very densely consolidated lung. And what's interesting is the CT on this read initially was she has some basilar atelectasis. And so this was an example where the lung ultrasound was actually better than the CT scan in this pregnant patient. And this can be done using the same exact probe that you use from an OBGYN standpoint. You can use this curvilinear probe and just essentially bring it up in the abdominal setting. You don't need a special preset or setting to do this. I had this woman here on the wards who had abdominal pain, nausea, vomiting. She had recurrent small bowel infections. She had multiple sort of GYN surgeries, developed some adhesions, and had several bowel obstructions. She came in nausea, vomiting. She had a CT scan. Looking back, she had probably about 20 CT scans in the last 5 years. And the CT scan was read as no acute obstruction in ileus. Really wasn't doing well. Belly was more distended, was just vomiting a whole lot. And when I saw her, she had dilated, fluid-filled loops of bowel. And so this is an example of a loop of bowel here. You can see the little plicae circularis kind of coming in here. And you can see that it's dilated. Anything that's greater than 2.5 centimeters is considered dilated small bowel. And then here you can actually see a little bit of food particles inside her fluid-filled small bowel trying to peristalse and go. Usually it's one direction, but you can kind of see it just has nowhere to go as there's an obstruction there. And so I showed these images to the radiologist. I said, you know, I really think this lady has a bowel obstruction. And he then took a look at, looking at these images, took a look at back at that CT scan, and he said, you know what, I think you're right. There's probably, I showed him where I was holding the probe, and he's like, you know what, there is actually a transition point right where you're telling me. So that would fit. So he changed his read on the CT scan. So. And then this is another example, big dilated loops of bowel here. You just sort of see it sort of washing machine sort of going back and forth, really nowhere to go. What's also interesting is that not only can you diagnose the small bowel obstruction better than a flat x-ray, better than that actually, the sensitivity and specificity is better, but you can also use it to diagnose the same conditions that are actually causing the small bowel obstruction. So in this case, you can see their incarcerated hernia, and you can also monitor them over time for the development of complications. And so this is a person who was sat on by the surgeons, and they just wanted to do conservative therapy over time. And then he developed an acute decompensation, got very sick very fast, needed to be intubated, and things like that. He had perforation. And you can see this kind of looks like lung, doesn't it? Doesn't it look like that lung point that I showed you earlier? But this is air inside his abdomen, kind of wiggling back and forth there. So, two more inpatient examples. So here is the COPD exacerbation. So, a guy who has admitted for respiratory failure. He was admitted a week ago for COPD exacerbation. He had an extensive smoking history, but no diagnosis of COPD. This was considered his sentinel event, COPD exacerbation, which always makes me suspicious. But he had hypoxia, was hospitalized for a couple days, got a couple nebs, steroids, things like that, was discharged, came right back to the hospital, very, very sick, worsening hypoxemia, and the resident had called us up and said, hey, I think this guy needs to go to the unit. I think he needs to be intubated. He's breathing, 35 times a minute. I think he's going to get tired out. I think he's not doing well on the floor. I think he needs to come to the unit. We went down, we saw him, listened to him. He doesn't have a whole lot of wheezing. Again, in somebody who's got respiratory failure, that makes you kind of wonder, why is that? That doesn't make sense. And he had totally clear lung fields on ultrasound exam, no B lines, no effusions, no consolidations. And so we then decided to take a look at his heart. And here, this is an apical 4-chamber view, so you can see 4 different chambers of the heart. This is his left side here, left ventricle, left atrium. This is his right side, right ventricle, right atrium, tricuspid valve, mitral valve. And normally, the left side should be much bigger than the right side. But here, what do you guys think about the right-hand side compared to the left-hand side? Do you think the right side's bigger? Looks bigger, right? You don't need to be an echocardiographer for this. You don't need to be a cardiologist. This side's clearly bigger than the other side. And he has no history of pulmonary hypertension, no history of any of that stuff. So in a person who has acute right-sided dilation, it makes you think of pulmonary embolism. And then we took a look down at his legs here. This is his femoral vein, this is femoral artery, and you can again see that he's got a thrombus just sort of sitting there. So he has a presumptive diagnosis of PE at this point. But he was too unstable to go to the CAT scan, so we treated him with lytic therapy purely based on these images. And he actually did very well. He had a rapid turnaround in terms of his tachypnea, and then we just watched over the next 3 days, we just watched his right heart essentially sort of shrink back down to normal size, and he actually left the hospital without any oxygen or anything like that, so he did surprisingly well. This is an example. I love to show this clip because I didn't obtain this clip at all. This is a clip obtained by one of my residents who was on the night wards at one of the VAs and had a guy who was post-operative from a femur fracture just post-op day 0. So this is the night after his surgery. And he was hypoxic. He had gotten a lot of fluids. They got a chest x-ray. They said there was some congestion on the chest x-ray. So they were diuresing him, and he wasn't kind of getting better. He took a look at this guy's lungs and found that, again, the lung findings didn't correspond with that, profound hypoxemia, didn't correspond with the amount of B lines he was seeing. So he looked at his heart, and you can actually see right there. Do you guys see that thing bouncing around, kind of like popcorn kernels and stuff? That's clot banging around in his right ventricle. That's a PE in progress. He urgently got this guy transferred to a place that did interventional radiology. They did a thrombectomy, a non-invasive thrombectomy, and probably saved this guy's life. And so you say, well, the standard of care is a CT scan for PE, and I 100% agree with that. The ultrasound does not replace a CT angiography for PE. It's not sensitive enough, it's not specific enough, and the stakes are really too high. But sometimes the CT scan is not practical, or you're not able to get it. Renal dysfunction, patients too unstable, those sorts of things. So here's a nice study where they looked at point-of-care ultrasound, looking at the heart, the lungs, looking for little wedge infarcts, as well as the deep veins to look for DVT, and they incorporated it into sort of an algorithm for how to behave. So if you had a low Wells score, a low pretest probability for PE based on that, and if you had a negative D-dimer, they ruled you out for PE. And that's standard, right? You can do that without ultrasound. But if you had a positive D-dimer, rather than jumping first to the CT scan, you had a multi-organ ultrasound. Or if you had a really high score, you went straight to the multi-organ ultrasound for PE. And if that was negative, and they found an alternative diagnosis, meaning they saw a bunch of B lines, or pleural effusions or pneumonias, or they found another reason for you to have your tachycardia, say you had a pericardial effusion or LV dysfunction. They found an alternative diagnosis, or if you had then a negative D-dimer. So if you had a high Wells score and then a multi-organ ultrasound, that's how you could still get to the D-dimer part. None of these patients had PE, which is pretty cool. It means you could selectively reduce a lot of patients from getting a CT scan unnecessarily. And then also, if you had a positive finding, and if you had a DVT present, then they just treated you without doing the CT scan. They found they were able to reduce the number of CT scans. They did a lot. Lots of exciting things here. I have a friend who's a family medicine physician, and she was going through some fertility things, and she was getting ovarian hyperstimulation syndrome, and she was short of breath and not doing well, and she unfortunately had to go into the ER, have this big giant workup, and had a CT scan because they were concerned about PE. She definitely had big old pleural effusions and some pulmonary edema. She also had ascites and things like that, but the alternative diagnosis there, she could have easily been spared that CT scan. And so this is probably one of the most common, this condition isn't common, but this is one of the most common mimickers, septic shock. A lot of times people come in with the sepsis and they're not doing well. And my ICU colleague was taking care of a patient who was admitted overnight, and then he took over the service the next morning, and the residents and the fellows are telling him about this patient who essentially has a lactate that had gone up from like 4 to 6 to 10. His creatinine had gone up from 4 to 8 to 10. His LFTs had gone sky high. All the markers of a person who's not doing well. And they're like, yeah, the working diagnosis is septic shock. He had a white count. He had a fever. They're not really sure of the source, but they're expecting the blood cultures to be positive. He had a history of, I think, some IV drug use or something like that. They're expecting this guy to die. And he walks into the room and his family, and he's talking to them, and he's saying, I'm really sorry, it's looking really bad. And he discusses kind of how things are looking, and it's very sort of emotional time. But he, as part of every single evaluation, evaluates everybody with an ultrasound of their heart if they're in shock. And when he looked at this person's heart, now unfortunately this did not project very well, I'm sorry, but when he looked at the image of this guy's heart, this is heart right here. And then this is the outside portion of the heart right here. This is the end of the myocardium. And you see how there is black around the myocardium here? And this is looking at the heart in a different way. You can see, looking through the liver, you can see black surrounding the heart, and you can actually see this part of the chamber here collapsing during diastole. And so this guy had tamponade. And so he called for a pericardiocentesis tray. They drained that guy's fluid, and within a couple hours, he was off of he was on like 4 or 5 pressors. He was now on 1 pressor, and then by the end of the day, he was off all pressors, and all of his organ dysfunction was kind of resolving, and this guy actually walked out of the hospital, saved his life. So, it's a sort of dramatic case. But I think there are certain things that in our institution we have lots of ultrasound machines available, and I think nobody should ever die of something like this when you have kind of a lot of machines available like that. And this is an example of shock and critically ill patients, and finding that this really does help. It doesn't completely replace your traditional physical exam, but it really does help a lot. And so most of you guys are probably not practicing inpatient medicine. Most of you guys are practicing sort of in the clinical setting, and even though or the clinic setting. And so even though the ultrasound uses and utility, and the sicker the patient, the more advantageous ultrasound is, the more apparent the benefits. But that being said, I do mix of both inpatient medicine and outpatient medicine. I have my own, faculty practice, and then I also, see patients in the clinic with the residents. And we serve, with the residents, we serve a group of people who are notoriously underserved, right? And they don't follow up, they don't get specialized testings, they don't see consultants and things like that. So I find this to be incredibly useful as a generalist in the clinic as well. And so this lady here, she was having fever, malaise, was not feeling well. She went to one clinic. They diagnosed her with a URI, gave her some Robitussin and some Tessalon pearls and things like that. She went to another clinic, was still not doing well. They did a UA and saw she had a couple of white blood cells and red blood cells in her urine. They diagnosed her with a UTI. They gave her some Bactrim. Still not feeling well, continues to do poorly, goes to the ER. They diagnose her with pyelonephritis because, she's having abdominal discomfort, abdominal pain, she's febrile, but, they gave her some fluids, they gave her some Tylenol, they gave her a dose of ceftriaxone in the ER, and she's feeling better, so they discharge her home. She comes back to the ER. They're thinking of discharging her again. We looked at her kidney here, and this is a normal appearance of a kidney. It kind of looks like a peanut M&M if you were to bite it in half and kind of like look at it on end. So here's the peanut right here, here's the chocolate, and then here's the candy colored shell of the kidney. So this is the middle of the kidney here. This is the collecting system of the kidney, and the collecting system is kind of dense and filled with this fatty tissue, and it's normally this brighter white, okay? When you lose that bright whiteness, when it becomes black, this black is fluid in the center of the collecting system. It shouldn't be there. And so this is what hydronephrosis looks like. And her right-sided kidney looked like this here, and her left-sided kidney looked like this. So she has a unilateral obstruction. And if you look carefully, actually, this is not super common, but in this particular case, you could totally see it. You could see a white object here with a little acoustic shadow coming off of it. Another white object here coming off of here. What do you guys think that is? Yeah, this lady had kidney stones. And so why was she febrile? Why was she, looking poorly? Well, she had infected, obstructed kidney stones. And so what do you do with people who have infection? You got to get good source control. You got to relieve that obstruction. She was about to be discharged. We called the urologist to sort of say, hey, she's got this obstructed stone. She really can't go home. We need you to come in, relieve the obstruction. She's not looking good. He was like, get a CAT scan. Oh, all right, we get a CAT scan. CAT scan shows exactly this. And he says, okay, I'll be in the morning. All right. She gets admitted. That night, she drops her pressures, gets really sick, gets septic. Ultimately, he came in a lot earlier than he was anticipating. But he came in early that morning. She was getting worse. He relieved the obstruction. She ended up doing fine. But had we discharged that person, she would have not done well on the outpatient basis, right? She would have probably done really poorly. Now, she might have, came back to the ER and they might have been able to save her, but this was a nice save. But at the same time, I can't help but think, what if her primary care doctor, who initially diagnosed her with a urinary tract infection and things like that, had taken a quick peek at her kidneys as part of just a routine examination of her and seen, oh, unilateral hydronephrosis, how much quicker in the process she would have been appropriately treated. And I honestly think that this happens way more commonly than we recognize that this happens. A lot of times people die sort of mysterious deaths of the sepsis, and we never determine the source. In the clinic, we also in addition to looking at the kidneys, we also look at the bladder. And we see a lot of incontinence evaluations, a lot of dysuria, type of complaints and things like that. In this case, this is a patient's belly. This is up here there's his umbilicus right here. This is the ultrasound probe, and this is us kind of bouncing up and down, you sure you don't feel anything right here? And so black is fluid, again, and so this is a big, well-circumscribed thing of black fluid, and if we take the ultrasound probe and we go from here and go down like that into the belly, we see all of this. And what do you guys think this guy has? Bladder obstruction, right? His bladder is coming all the way up to above his belly button. And this is actually, the more and more I look for this, is because I've included it as part of a routine exam, the more and more I find this. It's just striking to me how so many people come in with, vague abdominal syndromes, or even just tachycardia, demented patients, altered mental status, a lot of times, just vague, non-specific stuff, and it's something as simple as a bladder obstruction. This is readily diagnosed. Where this is also helpful is in people who you're doing a bladder scan, and they're saying there's lots of fluid in the bladder, and you go and you put in a Foley and you get only 50 cc's out. Like, what the heck? A lot of times the bladder scanners can't distinguish the bladder from ascites. And we've actually seen a person have their very empty bladder perforated from a very aggressive Foley catheter because you're trying to go into an empty bladder, and the whole time the bladder scanner's greater than 999 because the belly's filled with ascites. So in the clinic, I find that this is very helpful, not only to very quickly assess people's bladder size and rule out sort of overflow incontinence very quickly, but also we'll have them, if they're complaining of incontinence and things like that in the clinic, we'll actually have them void in the clinic. And if we see that, hey, they still have a fairly large bladder, we can actually do quick measurements and do a volume assessment of the bladder right there in the clinic and recognize that dysfunction. Another thing is how many of you guys are comfortable looking at the back of the eye with a fundoscope? Anybody? Any brave hands? I'm admittedly pretty terrible at looking at the back of the eye with a fundoscope. I have to use one of those panoptics, and then I'm only moderately comfortable, moderately confident. And I hate when the patients come in the clinic and they're like, yeah, I have a headache, and then you look at the vital signs, and the triage vital signs are like 220 over 115. You're like, oh man. And so looking at the patient's eye with ultrasound, you go, what? we put a tegaderm over their closed eyelid here, and then we just put a heaping thing of gel over top of the eyelid and scan through the gel, through the eyeball. And instead of actually looking at the back of the eye, you say, oh, can you see papilledema with ultrasound of the eye? And you can. You can see a little scoop up here with the papilledema. This person doesn't have papilledema. You can. But I'll do you one better. You can actually look at the optic nerve as it courses back to the brain. Why is that important? The optic nerve sheath is contiguous with the dura mater of the brain, and it's surrounded with a little bit of CSF. And as the pressure increases in the brain, that comes down the optic nerve sheath and causes it to widen and dilate. This is one of those NASA things that we kind of figured out. And so you can actually, in real time, monitor somebody's intracranial pressure in a non-invasive way. They did studies with pigs and rhesus monkeys and things like that, where they would artificially jack up their intracranial pressure and watch the optic nerve sheath kind of get big, and then they would drop the pressure and then sort of watch it in real time just kind of shrink back down. And there are cutoffs. This is being used in intensive care units and things like that, but how helpful in the clinic is it just to kind of know and be reassured like that person with the blood pressure walks around, 230 over 115 complaining of a headache, or that person who has an old VP shunt and you're like, gosh, is it malfunctioning or something? You can very quickly just get a nice reassurance, the pressures are low. I had a patient or a colleague over in Spokane, Washington, diagnose somebody's brain tumor by looking at their optic nerve sheath. So it's exciting stuff. How about in the clinic? This patient of mine came into the clinic, was complaining of chest pain. She had been in a motor vehicle accident a few, I forget what it was, days or weeks or something like that. But she was complaining of this very sort of pleuritic chest pain, cough. It was a very confusing history. She was all over the map in terms of thinking she had sinusitis and it had gotten into her chest, but I was thinking, oh man, I hope she doesn't have a pneumothorax or something like that. She ended up having an ultrasound of her lungs that looked something like this. So do you guys remember retention from earlier? What do we call these? Yeah, B-lines, right? And so is this suggestive of normal aerated lungs or wet lungs? Yeah, wet lungs, exactly right. And so, and then here, her IVC size 2.8 centimeters. Does that look big or small to you guys? It looks pretty big to me, right? But you can then go one step further and actually take a quick look at her heart. And I think this scares a lot of people, but I think this is really something that you can start to incorporate into your practice with just some basic training. This is looking at the heart sort of in cross-section. I'll go over this, but I can look at this picture right here, and this is an image a resident got of this lady. I can look at this image and know immediately she has heart failure with reduced ejection fraction. And then also, with incorporating the lung and IVC findings, recognize that she's actually decompensated heart failure with reduced ejection fraction. And we did this in about 5 minutes. And so, how do you do this? Well, you hold the probe like this, and you're taking the heart here, and you're slicing the heart along its true long axis, which unfortunately is not straight up and down like this, and it's not side and side like this. You have to kind of come across it like this. And so the probe is essentially just sitting right just off to the side of her sternum, and what you're looking at is you have the right ventricle here, you have the left ventricle here, you have the mitral valve kind of flapping open and closed, you have the left atrium here, the aorta here, and the aortic valve right here. The only thing that I'm going to have you look at is that mitral valve and the interventricular septum right here, and see how it almost looks like it slaps up against the interventricular septum here. This is what normal left ventricular function looks like. When people have severe left ventricular dysfunction, the LV chamber here dilates, and it stretches this distance from the anterior leaflet of the mitral valve from the interventricular septum. And this valve here almost looks like it's stenotic, right? It almost looks like it's just kind of barely, what I like to call burping open. It's just barely moving at all. And this distance here, you can use a 1 centimeter cutoff is kind of your normal from abnormal. And this is a 1 centimeter hash mark. So what do you guys think the distance between the valve tip to the septum is in this patient here? It's like 3-4 centimeters. Right? It's clearly more than 1 centimeter. You can very quickly diagnose somebody with LV dysfunction. And more people that I look, they have hearts that look like this, and they actually have skinny little ankles, and they're relatively asymptomatic, but until they sort of acutely decompensate. And so this is how you can just rapidly get one picture of the heart and then just use one little sort of dirty shortcut and pick up a lot of people with severe LV dysfunction. Just that 1 centimeter little cut point. Now this person, following up from the ER, seeing me in clinic, has had chest pain. He works as a cardiac cath tech, and so he was very concerned about his heart with his chest pain. And he had several ER visits, was evaluated at least 2, I think maybe 3 times before he saw me in clinic. He had had a fall that week, and then the chest pain had started the following morning. He was sore all over from his fall, but then the specific chest pain he was concerned about, he didn't notice until the next morning. And then he had several ER visits trying to evaluate his heart, and he was just not reassured by their evaluations. They did a chest x-ray that was normal, they did EKG, they did a stress test on him that was actually normal. He just was very concerned about his heart. And they were like, well, we can't find anything. We don't know why you're having this chest pain, but it's not your heart, you're fine. And he saw me, and he was having this chest pain, and I said, is it, specific to a spot? And he's like, it's kind of all over. It's, several spots all over, but, it's here, but then it kind of also radiates around over here. And I said, okay, well, what I want you to do is take this probe and put this probe where it hurts the most. And you put the probe right about here. And then right about here, this is what I saw. Oh! So remember, white is very dense, and so this is actually white with shadow. So this is bone, and this is his rib right here. Who wants this rib? Nobody wants this rib, right? I look at this, and this makes me cringe every time I watch it. I'm just take a deep breath, and he's like, oh! That is a rib fracture. That's how you can diagnose a rib fracture using a point-of-care ultrasound. And this is a very normal chest x-ray. He even had a rib series that was normal and things like that. And you say, well, he didn't really have a rib fracture. You just have some sort of illusion with your voodoo ultrasound thing going on there. And this is a normal rib here. This is his rib, and this is in cross-section of the rib, so you're looking at kind of the rounded edge. This is the spot that was acutely painful, so you can see this step-off deformity. This is rotating the probe now along the long axis of the rib, and so you're seeing sort of this nice step-off deformity here. And just for good measure, I brought him back several weeks later to look, and he did, to prove that it was all acute and things like that. And he formed a nice little callus over top of the bone here. You can see that callus forming over top of the rib. So you can't image the full bone, but you can see the surface of the bone. And that's fantastic for looking at small little fractures, especially when they can tell you exactly where it hurts. It's not useful for the person who's like delirious and unconscious and has polytrauma and they're just out. There's way too many ribs to scan for it to be effective, right? But in a person who can talk to you in the clinic and say, it hurts here, well, you put it right. I'm going to step away. If I approach you with the probe, that's something I've learned is I actually make them put the probe on, because if I put the probe on and cause them pain, they'll swing at me. So so this sometimes the point here is that from a healthcare utilization standpoint, this guy was a high utilizer because he wasn't reassured. He didn't have the answer. And this helped me counsel him, this is why you have your chest pain. And then he stopped going to the ER and stopped being worried about his heart and things like that. And there's so many conditions that are kind of like that. When we can actually explain to our patients why they're having their symptoms and show them, like he could understand this. He's not like he's an educated guy, but he's not, he's not a physician or anything, and he could easily look at those images just as you can and say, yeah, there's a problem there. Also in the clinic, kind of with the extremities, very nice to have a red swollen limb. You can look at this, and again, black is fluid. There's a nice, well-circumscribed little collection of fluid in this person's skin. And you can readily diagnose somebody who has, is that in that red skin with the cellulitis, is there an abscess in there? Okay, and so you can distinguish between abscess and cellulitis. When they have cellulitis, what happens is you get a lot of just swelling kind of all over, and there's no clear collection of fluid. There's a lot of like fluid in the tissue, and that's what causes all that edema and stuff like that. But there's no collection. This is what we call cobblestoning, and so you can see this with edema, but you can also see this with cellulitis. This helps you distinguish, the person who does or does not have an abscess. And where I like this is in clinic is when I'm like, do I do just an IND just because there's an area that's right here in the center that seems to be a little bit more indurated and things like that. And you can essentially kind of be very confident that they do not have an abscess and just treat them with the antibiotics. And that's very quick, easy thing to do, and also an easy thing to learn with point-of-care ultrasound. Now, where this is also helpful is in figuring out, again, just like the thoracentesis and the paracentesis, when you shouldn't be doing that IND, all right? And so this is on somebody's arm, and we're taking the probe and we're just kind of gently pressing on their arm with the probe. And you guys see this nastiness kind of swirling around. What we call this is sonographic fluctuance. This is liquid hot magma kind of going back and forth beneath the surface. This tract from here all the way up to here, right? And so had I done the IND just where that area of fluctuance was, then I would have missed the fact that he's got a surgical problem. I'm not the droids he is looking for, right? And so I can't do just like an IND of this in the clinic. He needs to see, a surgeon. So that's helpful there. And then an ascites. Ascites is such a straightforward, simple thing to use ultrasound to diagnose. It's so simple, but it also helps as far as that, not only the diagnosis, but also the management of that patient. And I think that's an underappreciated thing that's become apparent to me in clinic, is so many decisions that I make hinge on whether or not their ascites is getting worse or getting better, whether they have ascites or don't have ascites. And it's very, very simple, but can be very difficult with a traditional exam. Both of these patients have a history of liver disease, alcoholic liver disease. Both of these patients have a history of ascites. Both of these patients were taking Lasix and aldactone, and were then starting to kind of feel like, I really hate these medicines. I don't like the way I feel taking these medicines. Can I come off of these medicines, or do I need to go up? Both of these patients, I think one of their complaints is that they were gaining weight, and so then you're like, oh, we got to increase your diuretics if you're gaining weight. Which of these patients has ascites just by looking at them? We're going to take a vote. Who says the image on the left, they have ascites? Any takers? Who says the image on the right, this guy? So I had no takers for this one. This lady has tons of ascites. He has none. None. Okay? You might think, oh, he's got a very round, protuberant abdomen. Well, this is a guy who used to not he used to not eat a whole lot. He would drink a whole lot. And since he stopped drinking and he's been abstinent, he's actually now eating like pig, and he's gaining weight, he's getting fatter. And so he had central obesity. She still had a bunch of ascites left. And in the long term, she actually is not doing great. We're evaluating her or trying to get her set up for a liver transplant. But she kept stopping her diuretics because she felt poorly and was not, she was intermittently compliant and things like that. And she's like, I don't think I have ascites anymore. I think it's better. And I was able to show her and convince her. And I threw this in here because I like physical diagnosis, and one of the things we hang our hats on is like, hey, do they have lower extremity swelling or not? And both these guys had stick ankles. It's not 100% accurate. So yeah, they have ankles like me. So how do you do this? This is not going to project well, unfortunately. I apologize in advance, but we use the liver as the acoustic window, and we use the same view that they do in a fast scan for trauma. We'll use the liver as the acoustic window, shine the beam through the liver, through the kidney, and then hit the vertebral bodies about here, and we'll angle posteriorly. And in a person who's supine, that fluid will collect actually between the kidney and the liver. And so this is this CAT scan is oriented as if the person's on their left-hand side, and you're looking at them from back to front, which is how the ultrasound on the screen is imaged. And so, unfortunately, again, I apologize. This does not show well. If you come to the hands-on session, I'll show you. But the liver here is right here. The kidney is here. And the space in between the liver and the kidney is here, the vertebral bodies is here, and that's where fluid tends to collect. And this is an example where there's no black fluid in between the kidney and the liver. And in this case here, you can see, I guess it doesn't work. Here, I'm going to come up here, see if that works. No? All right. That's all right. Yeah, great, thanks. And can you click on the one on the superimposed on top of the CT scan? Yeah. And so this is the ultrasound image sort of superimposed onto the CT scan to scale to kind of show you the orientation and things like that. So this is kidney, this is liver, and then the orientation's all the same here. And this is the ascites track in between here and here. And you guys notice that there's almost looks like a little rough texture and stuff. So you can actually sometimes see cirrhosis using this technique as well. And so my last clinic case here is a middle-aged female who presented to the office with a chief complaint of, I think I pulled a muscle. I was helping somebody moving a couch, and I developed this abdominal pain. It's kind of down around in here. It's sharp. It kind of bothers me. Every now and then I'll be coughing and it'll irritate me. And so based on kind of hearing that kind of story, you guys think, she's got hernia or something, right? She's moving a big old couch. That's what I was thinking. I was thinking hernia. I do an ultrasound physical as part of my patients whenever I'm kind of not sure, and her chest portion of her ultrasound physical is completely normal. But I get to here, and this is what I see. I got my probe right here. Whoop. Got my probe right here. And so shooting across here, based on what I told you before about the free fluid, you guys see this little bit of black right around here, right around her liver, in between the kidney and the liver. There's fluid there. I was like, oh, not good, right? And then, kind of also looking here, looking at her kidney. See how that doesn't look like a normal peanut M&M? There's a little black in there. She's got a little hydronephrosis on that kidney. It was not present on the other side. Not good. Go down, look at her pelvis. She's got fluid in her pelvis. She's got a big old mass right here. And what I'm doing is gently just kind of pressing with the probe. You can see the fluid kind of swirling around. You can see this mass kind of floating in all this fluid. I was like, we got a problem. So I was able to very quickly triage this person who I'm thinking, going to give some NSAIDs, counsel her about inguinal hernia, see if it gets better. If it doesn't get better, I'll send her to a surgeon and things like that. After this, I was essentially like, we got a problem. You need a CAT scan. That pre-authorization form, super easy because I was able to click, was this finding confirmed with any other ultrasound imaging? I was like, yes. If very easy to get that pre-authorization form. She had a CAT scan within 2 days, and she was in the oncologist's office within a week. And so she had, ovarian cancer. We were able to recognize that very quickly. And even though, it's gonna crash. But so even though, she had a bad diagnosis, we were able to recognize that very early. And then I was able to counsel her as a primary care doctor, counsel her very appropriately, and all of a sudden sort of that happy kind of like, well, it's probably fine, and we'll see, like we were able to kind of set the tone of that visit very quickly in terms of kind of figuring out what's going on. Yeah, that go up a little bit, right there, that one. Mm-hmm. Yeah, that one. Just hit the projection down the bottom right, the little projector. Yeah, right there. Yeah. And so, so these are her CAT scan images. You can see the hydronephrosis. You can see the fluid. And do it again. Okay, here we go. All right. And you can see her, ovarian mass and ascites. And so when you're first learning ultrasound, and this is true when we teach ultrasound to all of our medical students. It's actually incorporated into our 4-year curriculum. We teach ultrasound as part of our internal medicine residency curriculum as well as our family medicine, and we're initiating a PEDS program and things like that. When you first start learning about point-of-care ultrasound, without any clinical, kind of backdrop, it can be very tempting to kind of be like Mickey and think that the ultrasound is kind of going to be like putting on the magic hat and give you super awesome powers. And you're going to wield this ultrasound probe, and it's going to be super awesome, and you're going to diagnose a ton of people and things like that. And if you don't start right, it can be very quick to happen where you essentially get quickly overwhelmed, and you're like, oh my gosh, there's way too much stuff for me to learn. The scope is way too broad. I only have this much time. I can't be learning all this stuff. Like it's way too broad, and you can feel very overwhelmed with trying to learn this, trying to tackle this. And so I think it's important to have good beginnings, good start. And so a misconception for some people is that if you're sci-fi fans or anything like that, that the portable ultrasound is developing pretty quickly. Right now we don't even require wires and stuff. Pretty soon, maybe they'll find a technological innovation that allows us to get rid of all that gel. Gosh, I hope so. Please. Right? And so, and maybe you won't even need to sort of actually put the probe on the person. You can just sort of scan through air, and then who knows. So, but ultrasound is not kind of like the tricorder, okay? The tricorder, you just kind of wave around and it tells you what's wrong with the person. The ultrasound is much, much more like Linacs stethoscope, right? It is, the pediatric cardiologist, when I was a med student, we would hound him for like, he's really good at murmurs and stuff. We'd be like, what's the best stethoscope to get? Which stethoscope should we really get? You get the inside track. And he'd be like, the most important thing to have with a stethoscope is what goes between the earpieces. And we'd be like, ah. And the same is true with ultrasound, unfortunately. Fortunately or unfortunately, depending on your point of view. And so if you are a terrible physician and you have ultrasound, that's not going to make you necessarily a great physician. But I think that if you have ultrasound and your physical exam skills and things like that are weak, it's going to take you to a better level. It's going to improve your diagnostic accuracy. It's going to help you get better. And you can take somebody who's really good and then get them so they're diagnosing everything. They're awesome. But that's not to say that if you can't get to super awesome, that you shouldn't be allowed to use point-of-care ultrasound, especially if it's improving your otherwise, less optimal, suboptimal exam techniques. And so we think, we agree with sort of Bruce Kimura, who wrote this, nice little article on this. We agree that, pretty much everybody should at least be exposed to the opportunity to learn point-of-care ultrasound, and then whether or not they decide to kind of really take it and run with it, will be up to them. But just because they can't obtain 100% sensitivity and 100% specificity doesn't mean they shouldn't be able to use point-of-care ultrasound. Because what are we comparing it to? We shouldn't be comparing it, again, to the formal studies, like the consultative imaging studies. We should be comparing it to what they can do at the bedside with their otherwise non-enhanced skills. And so it does require practice, and it does require a lot of thought and deliberation, and it's not necessarily, depending on the applications you're using, sometimes it's challenging. But that being said, I like the challenge. I like the idea that my physical exam is a craft. And I was one of the ways I got into point-of-care ultrasound is I'll tell you a little anecdote, is I was in the ER as a resident, and I was doing my typical internist thing over a guy who came in with, undifferentiated dyspnea, hypoxia, and he had COPD, and he had heart failure, and I was like hemming and hawing on, what does this guy have? Does he have CHF exacerbation or COPD exacerbation? I'm like, And so I'm back in my little corner, pontificating as an internist. And the ER guy, they do their thing. And I come back to them about, 30, 40 minutes later. I'm like, I really think he has COPD exacerbation. I'm going to admit it for COPD exacerbation. This is what I'm going to do. And this ER resident, he was a colleague of mine. We were friends. And so I can say this. He was average at best from a clinical standpoint. He was not the sharpest knife in the drawer. And he goes, brah, he's got heart failure. I started him on Lasix. He's put out like 2 liters already while you're over there thinking. And I was like, what? How did you know this? How did you do this? And he's like, he's got beelines everywhere, brah. And I'm just like, I need this skill. And so I really liked, I started out with the physical exam and really kind of wanting to become good at the physical exam, to be able to diagnose people based on my clinical acumen and my skill. And I like that idea that I'm continually getting better. It enhances my autonomy. And all this stuff that we talk about in terms of burnout prevention, I think this plays a role. Because I like that focusing, and I like that working and refining my craft. So it makes me feel like the physical exam is not dying. The physical exam is just evolving. It's just changing. And I think that helps me enjoy my job. I love what I do. Absolutely love what I do. And the patients love it too. And so we wrote a little piece and this is in the Southern Medical Journal for the July edition. And so if you're SMA members, this is available to you for free online. And then we have a couple of copies. Anybody doing the course is definitely going to get a copy. And then I think we have plenty of extra copies if you're interested. The entire July issue is devoted to point-of-care ultrasound.
Like we have copies.
Lots of copies. Everybody.
Lots, but we've got it.
Okay. It's Oprah. Everybody gets a copy. And so we did a perspective in there talking about, not only our perspective, kind of using ultrasound to diagnose like a pneumothorax in the clinic, but also the patient's perspective. What did they think about it? They were really improved. It helped them understand things. And one of our colleagues out in Minnesota did a nice piece where they did an actual study on looking at, does using ultrasound help improve sort of patient understanding of their diagnoses, and does that help match the doctor's understanding of what's going on? Does the patient kind of have a better understanding of what's going on? So I think that all helps. And then honestly, it's returned where I most feel like I'm in my element, where I'm most happy and most engaged and most present in medicine is when I'm at the bedside. And so often we have all these pulls to get us away from the bedside, away from the patient. The information we need is in the computer. And so rather than talking to the patient, interacting with the patient, and examining the patient, we're getting all the information we need out of their chart and the record and things like that. Well, I'll tell you, I take better histories, more informative histories. In addition to my physical exam getting better with ultrasound, I take better histories as well. Because there's nothing like, scanning a person's heart and being like, do you have any heart history? And they're saying, no. And I say, I see your heart's not squeezing very well.
and it looks like your chambers are dilated. This has been going on for quite a long time. Are you sure you don't have any heart history? Well, I had a heart attack a couple of years ago, but the doctor told me if I took my blood pressure medicine, I'd be okay. Right? And so that kind of stuff happens to me all the time, where like, confronted with the facts, the honesty is actually a little bit more forthcoming. And so I find that the history and the physical of my time at the bedside is much more enjoyable to me. So now, I have listed here a lot of barriers, concerns, that commonly come up whenever we do point-of-care ultrasound talks and things like that. I have a number of them here. I plan to cover all of these here, but if I brought it, I would like to make this participatory. If you guys have any questions or concerns about point-of-care ultrasound, I'm going to have plenty of time for questions at the end, but if you have specific barriers or concerns about initiating point-of-care ultrasound, I would love to hear them. Anyone? Yeah.
Easy. Billing.
Billing. Okay, I will definitely make sure I talk about billing. Okay. Any other concerns?
Just blurt it out.
Well, you're hitting it right here, equipment costs and training.
Okay.
And getting it out there to use in the community.
Yep. Okay. I will definitely talk about that.
Anybody else? Just shout it out.
Yeah.
How do you know if you're proficient?
Proficiency assessment. That's a good one. I didn't include that one, but I'll talk about that.
Maybe not 100%, but
Yeah,
the
like,
hurdle that you achieve.
How do you know? How do you know? Yeah, exactly. Yeah, exactly. That's a great point. Great. Yeah. Okay. All right. So one thing, and the reason I have it lined out is equipment portability and availability. I think 20 years ago, that was a very legitimate concern, because from the workflow standpoint, to kind of have to take a big giant machine and kind of wheel it around, especially if you're going from room to room, or if you're in whether or not that's a clinic or whether or not that's in the hospital. I think that was a very legitimate concern. I don't think that that's a legitimate concern anymore, because we have so many now pocket-sized devices available on the market, and in the hands-on session, we'll have the opportunity to play with at least two. And so I don't think that's legitimate at all. The equipment cost is currently still a big factor, okay? But that is becoming less and less of a factor over time. It used to be ultrasound machines would cost hundreds of thousands of dollars. Now portable ultrasound machines, high-end, cart-based point-of-care ultrasound machines with several probes and things like that will still run you about like $50,000, anywhere between $35,000 to $50,000, $60,000. So they're still very expensive when you go high-end and you go cart-based. But then when you start scaling it down to these tablet-sized devices, when these go down to these pocket-sized devices, the costs are less than $10,000. And then some of those devices that actually plug into phones and things like that can run anywhere between $2,000 and $5,000. So you say, well, that's still a big cost. It's way more expensive than my stethoscope. Well, what's your computer cost? What's your laptop cost? A MacBook or something like that costs about $1,000 to $2,000. And if you were to say, I'm never spending that much money on an ultrasound probe because, it's just too much money. I mean, how many people here 20 years ago would think that they were going to spend $1,000 on a phone? Right? I mean, a phone used to cost, like $20, $50, right? Now you spend $1,000 on a phone? Well, even if the phone's portable, well, you're not thinking of where the technology is going. And the technology is going to the point where it's integrating AI, it's integrating remote monitoring and things like that. There's one of the devices you can actually plug in, and it'll use your cameras or your phone's camera to point at the patient, so you can see where your hand is on the probe, and then you can share your screen with somebody else who's kind of observing and going, oh yeah, you actually need to come down a little bit more, or you need to slide over a little bit more and stuff like that. They're developing that technology. They're developing technology that will sense where the probe is in space in relationship to the patient's body, kind of be like automatically looking at that image and automatically sort of syncing with AI to kind of say, okay, the screen's going to light up green when you've obtained kind of an adequate parasternal long axis view of the heart versus it's going to stay red if you're not kind of getting all the things you need to see. So, but the equipment costs, I think, is getting better. It's still an issue. One option to consider is if you're not sure like what ultrasound machine to get and whether or not it would work in your practice and things like that, they do have lease options available. And so you can try them out. So at least one of those companies will rent you a probe for, sorry, I wanted to make sure I left time for questions. So at least one of those companies will lease it to you for less than $200 a month, which from a personal standpoint might seem expensive, but from a practice standpoint, if you can share that with other people, that's nothing. That's a drop in the bucket of an operations department or operations budget. In terms of quality assurance, image archiving, sometimes people are concerned about if you're getting these images, how do you make sure that the images you're getting are meeting like a criterion standard? And this does require some infrastructure. It's nice to have kind of like a plan of supervision if you're doing this out in the community where you're kind of having a group of people who are providing some quality assurance. And there's some interest groups and things like that, and there's some research networks that are getting formulated in primary care to kind of explore those possibilities of whether or not people who are also learning ultrasound can QA each other's image in kind of like a Wikipedia type fashion, we police ourselves. But I think
get into the EMR as well.
Right. Yep. And so in order to bill, the key rate limiting step for the billing component is in order to bill, if you want to bill like they do with a formal study, but in a limited formal study, there's actually no rules and regulations that says you can't. Right, and so there's at this point in time, this has enough low under the radar type setting so that there's not this political legal system that prevents you as a primary care doctor from billing. You can bill the same for a limited echo that a cardiologist bills for a limited echo, which is relatively lucrative if you look at it from a cost standpoint. It's like somewhere between $100 and $200 per scan. But in order to bill, then if you're taken to task on that, they would then expect you to have saved archived images. The images actually don't have to be included into the EMR to bill. You just need a report of what you saw, and but you do have to be able to retrieve the image if you were audited. There is a lot of concern about litigation. I'll talk about that. And time concern, I will also sort of talk about that. And then the broad application scope of practice. But the key thing, as Dr. Petty brought up, is training. That seems to be the biggest thing. Where do you get this type of training? And the opportunities are not widely available. We run a CME course, but in addition to teaching medical students, we run a CME course. Places like the SMA are now starting to offer opportunities for ultrasound training, like here at this session in terms of hands-on workshop. But there's a paucity of training around the country, and we'll talk about ways that you can increase the demand for that by requesting it. But in terms of privileging, a couple of things. One, the AMA has come out and said this, and this has been since the 90s, that ultrasound imaging is within the scope of practice of appropriately trained physicians, and that each hospital and medical staff should review and grant criteria. But essentially what this says is each specialty should police itself. And that if you're getting a whole bunch of political pushback at your local institution for doing this, that's actually grounds for filing a complaint with the AMA. And so there's lots of guidelines. Most applicable to general practitioners and things like that is the AFP is working on coming out with some guidelines, and the ACP is working on it. But right now, the ones that are published and out there, the American College of Emergency Physicians has an extensive ultrasound guidelines that have been around since the early 2000s and are very, very useful to and applicable to the general practitioner, and they're written in a way that is designed to do that. But also critical care society guidelines are out there, and then surprisingly the American Society of Echocardiography, 100% on board with the development of point-of-care ultrasound and the use of point-of-care ultrasound by non-cardiologists in the appropriate setting. The Society of Hospital Medicine is also coming out with lots of guidelines as well, first starting with procedures and then moving on to diagnostic and monitoring ways. They have their own guidelines and pathways towards training and getting people sort of certified in point-of-care ultrasound. So does the American Society of Chest Physicians. So there's lots of things. I'm very proud that we've been able to kind of mobilize the American College of Physicians, which is this Leviathan organization, to resolve to start putting out guidelines for point-of-care ultrasound by internists, and the number of educational opportunities that they're starting to offer is really taking off and increasing now too. So you say, what about lawsuits? All these guidelines might not protect me against lawsuits and litigation. And to look at this, you have to look at the people who have been doing this for the longest, point-of-care ultrasound, and that's ER. And this ER study had an analysis of 20 years of all the lawsuits that were potentially related to point-of-care ultrasound in ER. And they were only able to find 2 successful cases of litigation against emergency room physicians regarding point-of-care ultrasound. And in those settings, it was for not using point-of-care ultrasound. They had an ultrasound machine available, they had the training, and they didn't use it, and the patient had a bad outcome, and they were sued successfully. But those are the only cases in the literature now. So it seems like not performing ultrasound seems to carry more liability. If you're doing it in good faith and have appropriate training, you're very well protected. So at this point in the talk, you may kind of be feeling like Obi-Wan Kenobi, right? You're just looking at the ultrasound probe as just another blaster, a crude instrument, and you long for kind of that weapon from a more civilized age, right? And so if that is your thought and feeling, I just want to cover a couple of brief things. I want to say, things like Holman sign, that we teach on medical students still in terms of DVT. If you look from an evidence-based medicine standpoint, the post-test probability for or against DVT doesn't change. Doesn't change. Whereas if you look like the negative likelihood ratio of a negative point-of-care ultrasound versus a positive point-of-care ultrasound, markedly different, right? If you look at pulmonary edema and you're saying crackles, well, if I hear crackles, that does increase the probability, post-test probability of pulmonary edema modestly. But if I don't hear crackles, does that rule out pulmonary edema? Absolutely not. Whereas you look at B-lines with ultrasound, no competition there. And so often in the clinic, we're like, well, they come in, they have respiratory symptoms, but I don't hear any crackles, so I'm not going to prescribe antibiotics, and or I do hear crackles, and I'm going to prescribe antibiotics and things like that in terms of pneumonia. Look at these numbers here. These numbers are abysmal, whereas with lung ultrasound, really good. So the point is that ultrasound is the sophisticated, elegant weapon you have been looking for. You just don't know it yet. It's not a crude blaster. And if we look at studies, this is a study from 2005. This is an old study. This is an oldie but goodie. They compared M1s with 20 hours of ultrasound training, specifically echo training, focus echo training, with a cardiologist and their stethoscope and their traditional exam skills. They have them go around the clinic and look at the different patients, look at their diagnostic accuracy. The M1s are in black. Look at the sensitivity compared to cardiologists here. So for many conditions, they blew the cardiologist out of the water. These are M1 medical students. And this is a great article. I encourage you guys to look at this article. This was in JAMA Cardiology, a nice little special communications about where point-of-care ultrasound is headed and how it's time to really include that as part of the physical exam. They call it insonation as the next step, and talks about kind of where point-of-care ultrasound is moving in the physical exam. And so now is sort of the time to sort of evolve. We've been teaching medical students for the last 9 years at the University of South Carolina, or at least over 9 years now. And this is the paper that describes all of that. If you look at the medical students across the country, there's over 60 medical schools that have now sort of since followed in those footsteps and have included ultrasound in some way, shape, or form into the undergraduate curriculum. And so these guys are coming. These guys are coming. And so you might be thinking like Darth Vader, it's too late. Nothing can stop my demise now, like just leave me, just leave me. And so if that's what you're thinking, look at the Southern Medical Journal edition. We have 2 great pieces by middle career physicians and late career physicians who sort of discovered ultrasound sort of late in their career and learned it and allowed it to change their practice. If you want to get online, one of the authors here, Janice Boughton, she writes a wonderful blog, Why is American Healthcare So Expensive? And so she goes around the world and she's remade her career to be evolving with point-of-care ultrasound. She was getting a little burnt out, discovered ultrasound, and now has reinvented her career. She does a lot of locum tenens work. She goes to Africa. She teaches medical students. She does a lot of different things now. Really, really interesting story, and she's a fantastic human being. If you're not doing ultrasound, where do you start? If you're inpatient or you're doing procedures and you're not using ultrasound to guide your procedures, you really do need to start there. That's becoming standard of care with AHRQ and things like that. But if you're not doing procedures, not doing inpatient medicine and things like that, you're wondering where to start, I would start here at this ultrasound physical, and I'll show you what that looks like, and then we do a hands-on workshop on it. But I would start small, just pick a couple of small applications, and then build gradually from there. And so this is our ultrasound physical. These are all the different probe placements and how we move the probe across the body. This article is detailing this, and our philosophy about this is in the Southern Medical Journal. And we look at the heart, the IVC, the lung, the spleen, the liver, kidneys, urinary bladder, peritoneum. We do all that stuff. And we truncate that big, busy stuff to simplify things. You say, wow, that still seems like a lot. And so what I've done is I've created this video here where we've compared a standard physical exam with the ultrasound exam. So we have the heart here, taking a quick peek at the heart, looking for fluid, function, chamber size, valves. Come down here, look at another view of the heart, different view of the heart. This is the apical 4-chamber view. This one's a little bit more tricky to get, but you can get it right there. And then from there, move into the epigastric view. Use the liver as the window, shine it up into the IVC here and dumps right into the heart. You can see the heart in the subxiphoid view. You can rotate it around and then look at the IVC through the liver here, central venous pressure, volume status, that sort of thing. Take some of that gel. Love the gel. Hate the gel. I hate the gel, actually. Look at the base of the lungs here. Look at the artifacts of the base of the lungs. Look for free fluid. Look at that kidney. Make sure that kidney doesn't look obstructed. You can actually see the aorta and the IVC from over here. If you get the right plane of cut, you can see the gallbladder. You can see whether or not the liver is enlarged by kind of coming down the side. You come over here, you look at the left side. Find the spleen, find the kidney. You essentially do the same things on the left that you do on the right, except a much more limited exam. Look at the base of the lungs, look for free fluid. And then take some of that gel, come down to the suprapubic zone. Use the bladder as the acoustic window. Check out the bladder size, look at the free fluid in the pelvis. It's really helpful to look for free fluid in the pelvis, and the person who can't lay down on your exam table is sitting upright in a wheelchair or something like that. And that's That's it. Right? And so this takes about 2 minutes to do. When you practice it, you become proficient. You become sort of an ultrasound craftsman. You can see I'm still kind of puttering away at my traditional physical exam here. And we look at all the different things that we can diagnose using ultrasound with much higher sensitivity, specificity than kind of with our traditional exam. I'm tired of looking at that. Okay, so we're going to skip ahead. So make sure you take a look at the journal. There's lots of places to check out online for education online. This is the Society of Ultrasound and Medical Education. That's great. If you go to the Ultrasound Institute for the University of South Carolina, we have a whole YouTube channel where we have all kinds of videos, instructional videos and things like that. You just Google YouTube USC ultrasound, you'll find us. And we offer CME. If you had to obtain just like you want a full immersive ultrasound experience and really see what's out there, this is actually local this year. It's an international conference, but this year it's being held in the US, and this year it's being held in Wake Forest, so it's not very far from here. It's in September. I strongly encourage you to go. International experts in ultrasound all converge at this conference, and it's probably one of the best ultrasound conferences that I ever attend each year. So that's really good. Twitter, surprisingly, is an awesome educational tool, and people share their de-identified, anonymous sort of cool cases. It's like a journal club. It's awesome. And so that's it for my talk. Unfortunately, I can't paint that big of a picture, but hopefully you guys agree and you are ready to take the red pill. So at this time, I thank you very much for your attention, and I'm very happy to answer questions that you have.
So has anyone looked at a system level of the impact of people doing portable ultrasound versus any reduction in high-tech imaging? If you're looking at a total cost perspective.
Yeah, that's a great question. Not at a overall systems level, because there are very few institutions across the country that have accomplished that. There's a guy up at Abbott Northwestern in Minnesota who has really set the bar real high as far as the ultrasound in internal medicine has gone. And they actually no longer do things like ACLS in their bypass patients and stuff like that, because the ultrasound is surpassed, and is now integrated. And so they've done a lot of things at a system level, and he's compiling a massive amount of data, but not much of that has been published. He published a small thing in the SMJ about what they do with sinus ultrasound and how they were able to reduce antibiotic prescriptions and stuff like that. But at a systems level, there's very limited data. There's some stuff in the ICU where they were able to say, okay, we reduced our chest x-rays by this much, and we reduced our CT scans by this much, and things like that, but only at a microcosm.